professor Gabriel Hortobagyi, che terrà la sua Lectio Magistralis.
Illustrious Rector of the University of Modena, Honorable President of the Consilio, Professor Conte, members of the faculty and the Ateneo, ladies and gentlemen. It is with humility and emotion I stand in front of you today. Because this is truly an exceptional occasion in my life. The greatest recognition one can receive is that of one's peers in the academic world. And this, of course, doesn't happen often. I work at a university that is well known, but is less than 150 years old. I graduated from another university that is less well known, and it is less than 100 years old. So to receive a doctorate from a university that approaches 1,000 years in history and tradition is truly exceptional. As the introduction, which overstates my accomplishments, but for which I am truly grateful, indicates I have had multiple interests in the area of breast cancer research. And just to place things in context, my initial training was entirely clinical. So as we go through my presentation, this is also a reflection of how much medicine has changed over the past 30 years. Those of us in this room are privileged in the sense that we have learned more about the biology of disease in general and cancer in particular during our professional life than during the entire previous history of humanity. And part of that is due to the marriage between the clinic and laboratory research. And that is what I call translational research. And what I'm going to show you today is really a reverse example of translational research, because translational research doesn't always start in the laboratory. Before I get there, I would like to recognize, however, that I wouldn't be here receiving this honor without the constant support and encouragement of Agnes, my lifetime companion. Thank you. Professor Conte mentioned to you that this year we expect over 1,100,000 new diagnoses of breast cancer. About half of these will be diagnosed in Western Europe and North America. The rest in the developing world. And while in Western Europe and North America, breast cancer is diagnosed earlier and earlier, resulting in increasing cure rates. When I started in oncology, and what is still the reality in most of the developing world, is an entirely different situation. I'll show you a few examples of what locally advanced breast cancer is. But just to define the topic of my presentation, neoadjuvant therapy is the first treatment before any other treatment, surgical or otherwise, is administered to a patient with cancer, in this case. It is also called primary or preoperative or induction therapy. And while most of my comments will be related to chemotherapy, similar comments could be dedicated to neoadjuvant endocrine or hormonal therapy. The reality in this situation is that when we started, these tumors were truly inoperable. No surgeon would approach them with any expectation of cure. Therefore, one of the initial goals was to convert these inoperable large breast cancers, which were considered truly incurable, into operable tumors. Subsequently, as we became more successful, it was to reduce the extent of surgery, which was truly radical in the initial years. Then subsequent hypotheses led us to utilize clinical response to therapy as an in vivo assessment whether systemic treatment was actually working, and to guide the administration of subsequent therapy. We hoped to increase disease-free and overall survival, and this sequence of treatment also provided us with a clinical laboratory that allowed monitoring of the biological effects of treatment. So this is what locally advanced breast cancer was when I started. This is what it is in most of the developing world. Somewhere between 60 and 80% of women in South America, Asia, and Africa are diagnosed in this stage. This is truly a disaster for womankind. So our initial hypothesis was that preoperative systemic therapy will reduce the extent of tumor and facilitate local and regional therapy. So we designed a regimen in which chemotherapy is the initial phase. Let's see. Followed by, in the case of a favorable response and reduction in tumor bulk, by surgery, radiation therapy, and ultimately for those patients for whom this was appropriate, endocrine or hormonal treatment. Our initial 700 patients were constituted with about half being truly inoperable breast cancer, and about another third with very advanced large tumors. Of these, we accomplished with chemotherapy a greater than 50% reduction in tumors. This is a two-dimensional assessment. In reality, a 50% reduction in two-dimensional assessment represents a greater than 75% decrease in volume. That's about 80% of patients, and this was our first attempt. Disappointingly, however, only 11% of these patients had their entire tumor, all detectable tumor, disappear during chemotherapy. In this complex slide, what I will try to show you is what we started with before chemotherapy and what we ended up with after chemotherapy in terms of extent of disease. And forget the many numbers, but the important part of it is that after chemotherapy, about 60% of patients reduce their tumor in an international classification by more than one stage. And only 4 of, in this case, 188 patients had growth of their tumor. So this was a fairly successful intervention. I mentioned that the median size of the tumor decreased by about 70%, and about in earlier breast cancers, about 1 in 4 achieved a pathological complete response. This is important because the ability of breast cancer to produce serious complications and death is due to its ability to metastasize. So what I show you on this slide is that not only are we able to reduce the size of the tumor within the breast, but that in about 1 in 4 patients who start out with breast cancer having already spread to regional lymph nodes, we can sterilize or eradicate cancer cells from those lymph nodes. This was one of the most important observations indicating that we were not only decreasing tumor size, but we were also eradicating micrometastases that could not be detected by traditional imaging studies. Now, this work was eventually taken into randomized trials by large cooperative groups. This is one of the initial studies, although this was not performed in locally advanced breast cancer, but earlier, smaller, although still very large tumors. In this study, preoperative versus postoperative chemotherapy were compared in 1,500 patients, showing and confirming our work, showing that about 80% of patients achieved an objective regression of greater than 50%, and about 10% achieved a pathological complete remission. This study also confirmed our previous work that the number of positive axillary lymph nodes, that is to say lymph nodes that contained tumor cells at the beginning, could be reduced by the administration of preoperative chemotherapy. So if one were to ask again the question, does preoperative or neoadjuvant chemotherapy downstage primary tumor and axillary lymph node involvement, the answer is a resounding yes. A second hypothesis was that preoperative systemic therapy will prolong relapse-free and overall survival by eradicating occult metastases, preventing perisurgical dissemination of tumor cells, improving the results of surgical therapy, and enhancing the efficacy of radiotherapy. There were a number of preclinical experiments that led to this hypothesis, which unfortunately we were unable to confirm. And in fact, subsequent randomized trials failed to show an improvement in overall survival compared to the postoperative administration of the same chemotherapy. And as the survival curves show from a different randomized trials, you get the same survival curve whether you administer chemotherapy before or after surgery. However, there are certain situations, and this is particularly relevant to locally advanced breast cancer, where the administration of postoperative chemotherapy is really not possible because you can't do surgery in the first place. This is the case with patients with locally advanced breast cancer that already have spread of their tumor to the supraclavicular and sometimes to the lower cervical lymph nodes. These patients used to be considered 30 years ago, and they are still considered in some parts of the world as incurable, having distant metastatic disease. We did not believe that, and with this combined modality treatment, we were able to produce complete remissions in these patients, and with these curves, which I call your attention, go out to about 20 years of follow-up, we see that approximately 25% of these patients are alive and well. Had we not treated them this way, they would all be dead. So does neoadjuvant chemotherapy affect survival? Well, not compared to the same postoperative regimen, but it does in patients who start with inoperable breast cancers in the first place. An important advantage, however, is that by administering chemotherapy before removing the primary tumor, you're able to monitor the effects of your treatment. Otherwise, you would administer treatment blindly. Were we able to produce local control? This is an important consideration because, as shown by one of the slides that Professor Conte showed of the work of a famous surgeon, Professor Halsted, The major problem with these locally advanced breast cancers before the introduction of combined modality therapy was that, yes, the surgeon could remove the primary tumor, but the tumor would come back with a fury in the local area. So local recurrence rates in the 50 to 80% were common. In this particular analysis performed by one member of my group, and again based mostly on patients with stage 3A and B, therefore the true locally advanced breast cancers, the local recurrence rates at 5 years were 9%, and at 10 years, 11%. Similarly, once we go out to 20 years, the local recurrence rate continues to be very low. We analyzed then what factors predicted local recurrence, and we found that the involvement of the skin, the involvement of supraclavicular lymph nodes, that is to say over the shoulder bone, the extra lymph node extension of tumor, and estrogen receptor negative or hormone resistant tumors all independently predicted for local recurrence. And that the more of these adverse factors a patient had, the higher the probability of local recurrence, the higher the risk of developing this. This will lead us in the future to develop more aggressive and perhaps more successful interventions to prevent this. A subsequent hypothesis was that neoadjuvant systemic therapy will increase the probability of breast-conserving surgery. Now remember that when we started, these huge tumors would not even let themselves be operated. So surgery in many was out of the question. Now that we have taken this next step, surgery was not only possible, but we could, in some cases, preserve the breast. On this slide, I show you the results of several clinical trials, including ours, in which breast-conserving surgery and fairly large tumors was possible in anywhere from 30 to 65% of patients. And the frequency varied based on the initial size and extent of the tumor and the selection criteria used by the investigators. Now, part of the problem is that if one imagines the primary tumor such as a single large mass, and if a complete response is total disappearance of tumor cells, a partial response, one would hope, would be a centripetal reduction in volume. But what happens in some patients is that the tumor breaks up in multiple small pieces, and therefore removal of a smaller volume is not always possible. This fortunately happens in less than 20% of patients with large tumors. But nevertheless, and as shown on this slide, you are left with residual islands of small tumor cells in some of these patients. This might preclude the possibility of of preservation of the breast. In order to reduce local recurrences after breast preservation surgery, we use a number of criteria that are stringently applied to minimize local recurrence. This way, while we preserve the breast for a somewhat smaller percentage of women, we really minimize the probability of local recurrence. And in fact, we have analyzed our failures in this case and identified these various clinical and pathological factors as predisposing women who achieve a breast conservation to a local recurrence. And on the basis of this, we have also found that the higher the number of these risk factors, the lower the possibility of remaining without recurrence. So we are now able to predict who is at higher risk and who is at lower risk for achieving a local recurrence, can select our patients better, and can offer more successful breast conservation therapy. So the question, the initial hypothesis of whether we could increase breast conservation rate can be answered in the affirmative. We can offer breast conservation rate to a high proportion of patients, in some cases more than 80% of those who start out with very large tumors. The next hypothesis, which was more biologically oriented, and this is where we started to incorporate laboratory research into our clinical research, was that response to neoadjuvant systemic therapy, as measured by pathological complete eradication, will correlate with long-term survival, reflecting the effect of treatment on micrometastases. So let me step back for a moment and explain that. One of the problems of breast cancer and other cancers is that when you diagnose a new cancer, you think you can remove it completely with a surgical operation, but there are already micrometastases. That is to say, single cells or small collections of cells that have invaded the blood vasculature, the blood circulation, and have established distant colonies elsewhere. And even if you remove the primary tumor, those distant colonies have the ability to grow, produce organ failure, and eventually death. So we felt that it was important to demonstrate that our treatment not only affected the local tumor within the breast and the regional lymph nodes, but also in micrometastases. So we found that the degree of response to neoadjuvant chemotherapy, meaning complete response or partial response or none at all, correlated with long-term survival. And the better the response, the longer our patients lived. This was, of course, an indirect suggestion that we were affecting micrometastases. More importantly, in those patients in whom there was no residual cancer deposits within the breast and the lymphatic nodes after neoadjuvant chemotherapy did the best. And these patients, this is all based in locally advanced breast cancer. These patients who before these multidisciplinary therapies would have uniformly died of their breast cancer, now were living up to 20 years. About 75% would be alive and disease-free if they achieved such a pathological complete response. This was also confirmed by other studies, such as this one from a large multi-center group. We also analyzed the residual lymph nodes, or the residual tumor in lymph nodes, again suggesting that the fewer the lymph nodes involved with tumor, the better the long-term prognosis of these patients. So we believe that we are affecting micrometastases as successfully as the primary tumor. Now, our next hypothesis was that the eradication of tumor cells in the regional lymph nodes had a greater effect on long-term outcome than even eradication within the primary tumor. And this makes biological sense because the tumor within the breast is not life-threatening, but the tumor that has already demonstrated the ability to spread to other tissues, other organs, is the one to watch. So we started to obtain biopsies of lymph nodes before chemotherapy. And we had about 400 patients in whom there were positive lymph nodes before chemotherapy. And we observed that about 1 in 5 of these became negative after chemotherapy. And those patients in whom this happened, so their lymph nodes went from positive to negative after chemotherapy, had the best survival, whereas those who did not achieve such eradication of tumor continued to relapse, develop metastases, and eventually die. We also observed that once that change from positive lymph nodes to negative lymph nodes happened, whether there was remaining disease in the breast no longer mattered. So it was what happened in the lymph nodes, in those tumor cells that had the ability to travel and to metastasize, that was important, not what remained in the breast. This was a fairly unique observation that many of our colleagues in other organizations have not to date recognized. The next hypothesis we developed was that breast cancer was not a single disease, but it consisted of multiple subtypes that were probably characterized by different molecular characteristics, and therefore they would respond differently to systemic treatment regimens. So the first approach was to look at fairly traditional histologic subtypes, and the two most common types of breast cancer identified under a microscope are invasive ductal and invasive lobular. And we found that invasive ductal carcinoma, using the same chemotherapy, was 5 times more likely to achieve a pathological complete response than patients with invasive lobular carcinoma. This is, again, a brand new observation that has not been known before. Now, we also observed that patients who expressed the estrogen receptor is a protein that indicates that that cell responds to hormonal stimuli. We observed that those patients who have that estrogen receptor expression were much less likely to benefit from chemotherapy and achieving a pathological complete response than patients who did not express that receptor. This is again a 4-fold difference, and this particular observation has now been confirmed by at least 6 other groups that engage in breast cancer research. We also observed that once such a pathological response was obtained, it did not matter whether the estrogen receptor was absent or present, because the prognostic meaning, the prognostic significance was the same. And this was reassuring, so we just have to find better ways to achieve pathological complete response. Now, killing cancer cells is not a simple matter because our drugs do not directly kill cells. What our drugs do is to convince the cancer cell to commit suicide. This is called apoptosis, a Greek word that is increasingly used. Now, you can test for this on a histological slide with a specific stain. And what I show you here is 2 different patients, and these are biopsies, where before chemotherapy, both had a low rate of apoptosis, only 1 cell staining for this particular stain. But the patient who achieved a pathological complete remission after chemotherapy, 48 hours later, showed a marked increase in the rate of cell suicide, demonstrating that that particular tumor was highly sensitive to the effect of chemotherapy, whereas this one, who did not achieve a pathological complete remission, showed no change. So we now had a new target for intervention. And we observed on a larger group of patients that those who achieved a pathological complete remission within 48 hours developed these high rates of apoptosis as shown by the blue lines, whereas those with lesser response only exceptionally did increase their rate of apoptosis. And others have also confirmed this, showing that the apoptotic index increased in many patients, and that these were the patients who responded best to chemotherapy. There are many other observations that have been made, correlations with clinical or pathological factors that correlated with good response to chemotherapy, and others where our observations did not bear fruit. However, there was not a single individual predictor in this list of experiments, and this took many years, that was precise enough to identify those patients who would respond and those patients who would not. And remember the slide that Professor Conte showed you, how we overtreat patients because we have no ability to identify those that benefit and those that need the treatment. So our next hypothesis to address this problem is that if we looked at the molecular characteristics of these tumors, we would be able to better predict response to systemic therapy. So technology came to our help, and in the mid-1990s, we started working with gene expression profiles. So the background of that is that we have approximately 30,000 genes, and every one of our cells has approximately 30,000 genes. But not all of them are active in every cell. And we hypothesized that cancer cells had activated genes that were not activated in other cells, and that by determining which genes were activated in cancer cells and which were activated in normal cells, we could determine the difference between cancer and normal. And similarly, we could determine by gene profiling which responded and which would not respond. And essentially, we accomplished that. On this slide, I show you a selection of 74 genes and about 20-some patients. And the result is you don't have to have a degree in statistics, that the heat map, the color differences are quite striking. These patients on this box achieved the pathological complete remission, and their gene profile expression, gene expression profile is quite different from these other tumors that did not undergo a pathological complete remission. Now, an analysis of this suggests that we have a positive predictive value of 75% and a negative predictive value of 71% for a total accuracy of about 70%. We are now confirming this in a prospective randomized trial to narrow down the precision of these observations and hope to convert this into a more practical tool that will identify individuals most likely to benefit and thus lead to individualization of therapy. However, these observations also led to new observations and new questions. We noticed that simply by doing gene expression profiles in these breast cancers, we identified a number of families of breast cancer that had similar gene expression profiles. And some of those are shown at the top. So we have the ERB2, the basal, the luminal, the normal-like, and the basal-like subclasses. These cluster in this computer analysis because their gene expression profile is close to each other, and they are different from the other groups. So the importance of this is that they have different clinical behavior. The survival of patients with these different categories of breast cancer is quite distinct. For our area of interest, it was important because we found that the pathological complete remission rate was quite high for these two groups, the ERB2 and the basal subtype, and quite low for the other three. So this already took us one step further in identifying patients more likely to benefit and patients less likely to benefit from chemotherapy of this particular type. Furthermore, we observed that the genes that predicted response to therapy were actually different in each subgroup. That's generating many new hypotheses for us that we are currently exploring, some in collaboration with other scientists such as Professor Luca Gianni and others in other parts of the world. This, I think, will lead us to better understand the biology of the various subsets of breast cancer and certainly take us much closer to individualized therapy. Now, the last few slides relates to the use of neoadjuvant therapy to introduce new drugs. Our current method for introducing new drugs takes many years and many thousand patients. It's a very expensive and very inefficient method. We predicted on the basis of a study we did 20 years ago, which I believe was the first study that introduced a non-cross resistant regimen, that using two different chemotherapy regimens with different drugs would be more successful than using one single chemotherapy regimen. And in fact, in a relatively small study, we found positive results suggesting that the crossover was more successful. This has since been confirmed by other investigators and cooperative groups. When new drugs such as paclitaxel came along, instead of validating their efficacy in the adjuvant setting, which has required over 15,000 patients in multi-center trials, we were able to do that in a relatively small study, including about 500 patients. And we did this in the neoadjuvant setting. And we are able to do that because we can observe the response of these patients to treatment. We can observe their molecular profiles and monitor the effect of treatment on their molecular characteristics. And in fact, on a longer term, we found that the reduction in recurrence rates was in the same ballpark of about 24% as that observed in much larger adjuvant studies. We used this particular approach to compare two different sequences or two different schedules of administration of the same drug, which normally requires many hundred patients. In fact, there is a very large study of over 5,000 patients that we have been waiting for 6 years. Well, our study that was much smaller, over 250 patients, already showed a significant difference, indicating that the more frequent administration was superior to the less frequent administration. So the introduction of new drugs can probably be performed more efficiently using the neoadjuvant setting than the adjuvant setting. The last part of the introduction of new drugs relates to a new molecularly targeted therapy called trastuzumab that only affects cancer cells that express a very specific genetic abnormality, the HER2 overexpression. Now, in these particular patients, when trastuzumab was added to standard chemotherapy, the pathological complete response rate was reasonably high, about 20 to 30%. We designed a different study in which two sequential chemotherapy programs combined with trastuzumab were used instead of one. And this led us to a much higher rate of pathological complete response, about 65%, which has caused quite a stir among our colleagues. Now, these results, which are based in a small number of patients, are now being confirmed in a large multi-center trial. However, if they can be confirmed, and I'm confident they will be, they can then lead us to a much more efficient type of clinical trials to accelerate the development and validation of new drugs. Now, neoadjuvant chemotherapy then has taken us from a clinical sequence to an interaction with the laboratory and then a back and forth between the laboratory and the bedside. This is true translational research, and we hope to continue this. From the clinical perspective, I think continuation of this approach will lead to decreasing extents of surgery. We have already reduced the frequency with which radical breast surgery is performed. We hope to eventually decrease the extent of axillary surgery too. In some cases, we might be able to treat breast cancer without any surgery, which I'm sure our patients would be grateful for as long as we can show equal or higher cure rates. More importantly, I think this technique or this paradigm will take us to more individualized therapy by the routine use of molecular profiling, the selection of treatment based on such genetic profiles, the identification of the tumors that do or do not benefit from this intervention, and thus identify those patients who will best respond to a particular treatment. This also has some potential societal benefits, since it will reduce the cost, the duration, and the number of patients required to develop and validate a new treatment. We hope that this will be adopted in a larger world, and that it will take us to the next step in our quest to cure breast cancer. So I've taken you from a very bad group of breast cancers, which unfortunately still plagues women around the world. We are fortunate in Western Europe and North America that locally advanced breast cancer today represents less than 10% of newly diagnosed breast cancers. But our responsibility doesn't end with our borders, and cancer certainly does not know continental limits. So it is our responsibility not only to improve the treatment for our own sisters, mothers, and wives, but also those of others across different continents. I'm again honored and thankful for this wonderful recognition, and I hope that our collaboration between our two institutions will continue and accelerate the pace of progress. Thank you very much for your attention.
A cerimonia conclusa, il Rettore ringrazia tutte le autorità e i graditi ospiti per essere intervenuti a questo importante evento accademico. Infine un grazie sentito al coro e all'ensemble strumentale universitario diretto dal maestro Antonella Coppi, ai professori d'orchestra Federica Chiappori, flauto, Giulia Malagoli, violino, Davide Berselli, viola, Andrea Gualtieri, pianoforte.